So we have the talk I'm going to talk about is the gearbox. So the two components. I'm going to talk briefly about wires. I'm not going to bore you about wires, and James is going to talk about the microcatheters and guide extension. So it's important, very, very important, that you choose the right tool for the job. As mentioned earlier, CTO wire landscape is very confusing. We've talked about the different approaches: antegrade, retrograde, dissection, and reverse card. There are essentially four major approaches, but with hundreds of wires, and it keeps growing. It's not magic, though. You got to think about wires in this perspective. I found it very, very useful, and there are different ways of looking into it. I look into a wire in which I would access my CTO. I call it access wire. Then we talk about wires in which you use for penetration, such as what Jonathan used, like a CP12 to penetrate the cap. There are wires that are preferentially used for crossing microchannels. Some wires are specific, would do the job for collaterals. Wires in which you can use for re-entry, like again, Jonathan showed an example when he had the Stingray balloon and he used the Stingray wire to re-enter. There are specific wires that we use for knuckling, and of course, externalization wires. The reason I'm putting the anatomy of a wire, I mean, I still till today get very much amused of how these people could do engineering of these wires. It's a 0.014 or 0.008 or 0.10, and if you think about the technology that people have invested into with science and engineering to make these wires work for you is amazing. So there's different components. We talk about tip, we talk about the core, the coils, the covers, all that kind of stuff comes into play, in which would help us to really use the wire that we need for a specific task. So two cardinal questions that we have is, with wire usages, what am I trying to do? And what wire design element that enable us to do that function? Coming back to the task-specific wires, examples of microchannel tracking. If you have a microchannel, you think about Cyan, Fielder, Pilot 200, Gladius, Raider. There's a lot of them. You don't need all of them. There are wires in which you use for cap penetration, example of which we've used already, the CP12, for example, Gladius, Pilot 200, Hornet 14, Astato, and so forth. The typical wires that we use for knuckling is a Fielder XTR, the one I use, Pilot 200, Mongo, or Bandit. Dissection reentry wires, it's there already. Retrograde crossing wire, I think this is very important to keep an eye and try to minimize your wires as much as you can. Cyan wires are good for retrograde. I don't use any more FC, I think I should remove that from my slide. Fielder, Cyan, SUO3, or Cyan Black. And the externalization wire that I have in my lab is RG3. The collateral channels, I think we have more detail talked about it, but we have to really differentiate different types of collaterals. Are we dealing with epicardial collaterals? Are we dealing with atrial collaterals? Are we dealing with septal collaterals? Because each one of them is different, and crossing them is slightly different, and the complexity of passing through them are also different. The safest one of which is the septal, because it's you can dilate the septal, you can surf through the septal. However, the atrial or other epicardial collaterals, surfing is not recommended, and because of tortuosity and risk of rupture. And you certainly, epicardial collaterals, please do not dilate them. You can dilate the septal collaterals if you want, but not epicardials. The key for epicardials, because they have corkscrew pattern, as Simon Walsh would say. He says helter skelter, really tortuous. They have hidden side branches. So the trick for these epicardials is a little bit different. Typically, you use a very low tip load wire, such as a SUO wire, and a very microcatheter, such as the Caravelle or the Turnpike LP, which we will talk about even more. Just going to give you a glimpse of some of the wires, and the one that we used earlier, which is the Confianza Pro 12, was a 12-gram wire. It's a penetrating wire, and it's made of stainless steel. I don't remember all of these details, but it's good just to have an insight of how these wires are made and manufactured and what they do. The Hornet 14 also we use is a tapered wire, is 0.008, 14 grams. So the penetrating wires that I use, and maybe James is different, Simon, and everyone is. I picked two of them that I have in my lab. I have the Hornet 14 and I have the CP12, and if I escalate further, I go Astato 20 or 40. So these are the wires that I have, and penetrating wires in my lab. So the Astato is also, I use it occasionally when the wire is very heavily calcified. Remember when we talked about the penetrating wire, it's not meant to really cross the whole CTO body. It's just to penetrate the cap and then you immediately de-escalate, because this is not the function of this wire. So have a look at this example. This is a retrograde case. It's a microcatheter at the distal cap. The course of the vessel was not very clear, so what do? You could puncture the cap and de-escalate immediately, and you can, to assist the anatomy, you knuckle it with an XTR. That's how it looks. You start to do the knuckle, and then you advance gently your microcatheter, and you knuckle till you get to the area of interest. It's a continuation of that. I think I should have pushed the microcatheter even more close to the knuckle. One thing that one tip to recognize when the knuckle becomes big, and if you're going either antegrade knuckling or retrograde knuckling, if it's a big loop in here and then suddenly becomes smaller, what does that mean? You could have gone to side branch, or you jumped into the true lumen. There's a case in which it will be shown this tomorrow actually, which was it's a reattempt, and you can see how the knuckle would go straight and then boom, becomes into small. That was actually in the RV branch going antegrade. So continuation of the same. You walk it gently up. It's a very long, it's a very tortuous vessel, so without knuckling it would be very, very dangerous to put in a stiff wire going backwards. So some work antegrade, subintimal space, and then you do the same thing in the antegrade, and you connect them, and you do the reverse cart. And this is the final. So retrograde wire crossing, there are a few of them. We already talked about them. It's another thing is cyan. Sorry, it jumped. So retrograde, I don't know what happened. However, we already discussed the retrograde wire crossing. Think about cyan black, and SUO3. These are the common three wires that I use for those retrograde. Externalization, the one I use here is the RG3. Remember, it's a tip load of 3. It's a tip radial opacity 3 centimeters, but it is really hydrophilic, has a hydrophilic coating throughout its entire length. I found this very useful to think about wire selection. And if you're thinking going antegrade, you start, and you think there's a microchannel, you start with a fielder or a fighter from Boston. And if you know the vessel course, you can escalate further to the Gaia family, CP12 or Hornet 14. If you don't know the vessel course, then you don't use the stiff penetrating wire. You use the polymer jacketed wire, as we discussed earlier, either Pilot 200 or the Gladius or the Mongo. They're all about the same. And then these are for the retrograde we already talked. So if you keep this algorithm in your brain and thinking process, okay, if you believe that all the CTOs have a microchannel, use with the fielder and then escalate further up, depending on if you understand the course of the vessel. Wire shaping. There's specific ways of shaping these CTO wires. Typically, this is the way you want it to be, or sometimes you can do a double bend on them. But that's how you should and think about shaping the CTO wires. Coming back to the concept of the microchannel, these are the microchannels. Are typically the size ranges from 100 to 500 microgram. A typical 014 wire is 360. So occasionally when you use the XTR or XTA, you'll be able to really get into one of these channels and escalate further up. So remember we talk about dual injection, not much of panning, inject the donor vessel, and then you can see there's maybe a tapered cap in here, and then you use a wire that could actually penetrate the microchannel like the Fielder XTR or XTA. It doesn't matter, I'm used to XTR. And then you verify the position contralateral, keep going, and then balloon and stent. So CTO LED. So if we look into angiographic analysis, it's about a probably 20 centimeter length, even a little bit longer LED occlusion, feeded from the right, calcified, not terribly an ambiguous cap. So and it's heavily calcified. So if you use a low tip wire, it may not help you. So here if you go by the algorithm that we had earlier, we go with a low tip like the Fielder XTR. Maybe there is a microchannel with a microcatheter, escalate to Gaia second or Gaia third, and able to reach further down. Look at it in different views. And that should final. Okay. Don't know, for some reason it didn't work. All these videos are not working today. So again, another example of instant CTO. You do wire escalation, Gaia wire, Gaia second, Gaia third, get to the lumen, utilizing contralateral, and to finish the case. So Gaia is a wire that I commonly use as well in here. And this is again from James, how do you really use the Gaia wire. So it's you rotate gently with one hand and you push from the other hand, and you look at provided that you estimate the vessel course, and you look at it in two different views, and you gently push from your left, you feel resistance, you pull it back, redirect, and you go gently little by little till you reach to your distal cap. That's an example how you're going to use that. This is a post-cabbage CTO LED. I think there's a stent in here. You know the vessel course. Cap is not ambiguous. Take the Gaia. You find some resistance. You pull back. Redirect. And get into the vessel. So that's the push and pull thing. You go further down, and then when you go down, you can de-escalate the wire, put your workhorse wire, and finish the case. All right. So that's the final on that. So what I want you to think again in my summary for the wire. I know wire has been one of the most difficult things, even for me when I started, but when you look at it, really simplify it into the question is, what do you want the wire to do for you? So categorize it: a wire to access, wire to penetrate, which wire are you going to use for collaterals, which wires are going to use for externalization, which wire you're going to use for knuckle, then your life becomes much easier. So it's a lot of things that I learned from this book. I highly recommend these, the antegrade and the retrograde book by the iBook by Dr. Sprague. And that's really, if this book is this is the art of the Chinese art of war, the book written about 2,000 years ago about the art of war, how you really, which says if you know the enemy and know yourself, you need no fear the results of 100 battles. So if you want to learn CTO, I would highly recommend having a look at this book, Antegrade Retrograde book, because it has very simple, very conceptual, concept-related understanding of how CTO procedures could be done. So with this, I will leave the floor for James to give a talk about the microcatheters and guiding section.
Thank you.